Okay, back for more. Growth hormone excess, acromegaly. Let's see. Here's some of your symptoms: increased skeletal thickness and arthralgias, enlargements of the hands, feet, and forehead. The jaw may protrude. The skin gets thick and leathery, and generally it's oily. Soft tissues enlarge. The tongue can enlarge, producing a dysphagia. The upper airway becomes narrowed, which can produce sleep apnea. You get hypertrophy of the larynx, so the voice deepens. The organs can enlarge, particularly the heart and the liver. Patients who have growth hormone excess will very likely become diabetic. Growth hormone antagonizes insulin. And patients who have acromegaly have accelerated atherosclerosis because growth hormone mobilizes the stored fat for energy, increases your free fatty acids in the blood. All that produces atherosclerosis. I will probably flip through these slides again in class so that you can see them. But this is acromegaly over time. Here's age 9, 16, 33, 52. See the skeletal soft tissue changes, the thickening. This is a man with acromegaly. There he is as a young man, and then growth hormone excess. That's another picture of a lady affected. Diagnostics. You'll do a history and physical. You know, things like hat, shoe, glove size changes, headaches, visual changes, changes in the menstrual cycle, libido, arthritic pain. They'll do suppression tests, growth hormone and ACTH suppression tests. Diagnosis will require an assessment of the insulin-like growth factors and growth hormone response to an oral or an IV glucose challenge. The definitive test is the glucose challenge test. Normally, your growth hormone concentration will fall during an oral glucose challenge test. In acromegaly, the growth hormone level does not fall. They'll do an MRI looking for a tumor. They may do a CAT scan. They'll do a complete ophthalmologic exam, including visual fields, because a macroadenoma can cause pressure on the optic chiasm or the optic nerve. So then the treatment, surgical therapy is the treatment of choice. A hypophysectomy. Sometimes they'll do radiation before surgery to shrink the tumor. The hypophysectomy will be the best hope for a cure, especially if it's a microadenoma. They'll do a transsphenoidal approach, and I'll show you a picture of that shortly. They take an incision just above and under the upper lip. They want to remove only the tumor causing the growth hormone secretion, if possible. Sometimes they end up having to do a total hypophysectomy. Most procedures are effective. Some patients, especially if they have a large tumor, they won't get a cure. And as I mentioned, they may do adjuvant radiation or drug therapy to try to shrink the tumor. The total hypophysectomy will result in permanent abscess of your pituitary hormones. So your tropic hormones, those are not going to be replaced, okay? Because replacing those require parenteral administration. Rather, they'll take the hormones that the tropic hormones that are stimulated by the pituitary. I'm not sure if I'm saying that right. Rather than replace the tropic hormones that are secreted by the pituitary, they will replace the hormones that are now deficited. For example, they'll give glucocorticoids. Glucocorticoids are stimulated and released from the adrenal cortex in response to a tropic hormone from the pituitary. They'll give thyroid hormone. Normally you would have TSH in the pituitary, but they're not going to give TSH. They'll just give the thyroid hormone. And they'll give sex hormones. Normally you would have a sex hormone stimulating hormone being released from the pituitary gland, you know, FSH and LH. Those hormones have to be continued throughout life. Okay, and that's kind of important to realize. I mentioned the incision just above the upper lip reaches the pituitary gland through the phemoid sinuses. Now, after the gland is removed, they will do a muscle graft, a lot of times from the thigh, to support the area and prevent leakage of CSF. So if you look here, here's the upper lip. They make an incision. They go in through the sphenoid sinus, and they go after the pituitary. Now, pre-op care, they're going to do basotracin nose drops. You want that environment as clean as possible. Patient teaching, they have to mouth breathe. They have to do good oral care. No valsalvas, no coughing. Pain management will be important. Long-term hormonal replacement is critical. Post-op care, head of bed up. All clear nasal drainage will be tested for glucose to make sure it isn't CSF fluid. They will have a drip pad or mustache dressing, same thing. It goes under the nose. And if there's a CSF leak, you might see associated with that headache. A CSF leak will usually resolve within 3 days if you keep the patient on bed rest and you keep the head of the bed up. Sometimes they have to do daily spinal taps to decrease the pressure in the central nervous system. And they may treat with IV antibiotics. The problem with a CSF leak is now the patient is at risk for meningitis. They may have to give vasopressin. Vasopressin is the ADH, the antidiuretic hormone, if that's an issue. Thyroid and glucocorticoid replacements, and those hormones will be replaced forever. Now, patient teaching for hypophysectomy. Monitor nasal drainage. Avoid bending at the waist. Avoid straining. You don't want any Valsalva maneuvering. No nose blowing. You cannot brush your teeth for 2 weeks because the incision is right up there. Deep breathing is important, but not coughing. Monitor your fluid balance. You're looking for symptoms of antidiuretic hormone imbalance. The patient needs to report any signs of meningitis. Hormone replacements will be lifelong. Infertility treatments can be provided. Patient will generally have a decreased sense of smell for many months following this procedure. Other things that can be done besides surgery for growth hormone excess include radiation therapy. There is a pretty long delay for the growth hormone levels to normalize. They'll think about radiation therapy when surgery has failed to produce a complete remission. Radiation therapy can successfully reduce growth hormone levels in 30 to 70% of patients. But the main disadvantage is that there's a long delay, like 5 to 10 years, for those growth hormone levels to normalize. Radiation therapy is usually going to be offered in combination with drugs. Stereotactic surgery, stereotactic radiosurgery, gamma surgery, proton beam, linear accelerator, those are some of the mechanisms used. It works faster than your conventional. They'll deliver radiation to a single site from multiple angles. It's used to cut off the blood supply. The patient wears this kind of a frame that allows the machine then to be very specific about where it is angling the beam. The patient nursing staff needs to know how to remove the frame quickly in an emergency. You have to monitor the patient for headaches, seizure, nausea, and vomiting. Okay, got to stop with this segment.